Welcome to Deep Dive Ortho. We journey through complex clinical challenges, really trying to extract insights that are genuinely relevant to your practice.
Great to be here.
Today, we're navigating the intricate landscape of Charcot Neuropathic Osteoarthropathy. Now, this is a condition that, as many of you know, demands a really high degree of clinical suspicion,
Absolutely.
and it often presents significant diagnostic and management hurdles in everyday orthopedic care.
It certainly does. It's remarkably destructive.
Yes, a remarkably destructive joint disorder, and truly understanding its nuances, not just in the prevalent lower limb manifestations, but also its rare occurrences in the upper extremities, is paramount.
Crucial.
We're joined today by an expert whose extensive experience and profound understanding in this field will be our compass as we unpack this condition. The knowledge we're about to explore is crucial for expanding our clinical understanding on Charcot.
Hopefully we can shed some light.
Our mission today is to ensure that by the end of this deep dive, you, our listeners, feel exceptionally well-informed and, frankly, better equipped to tackle this challenging pathology in your daily work.
Let's dive in.
So, let's begin by grounding ourselves. Could you define Charcot Neuropathic Osteoarthropathy for us, and perhaps even more critically, explain why it poses such a profound and often urgent challenge in orthopedic practice?
Certainly. Charcot Neuropathic Osteoarthropathy, or CNO as we often call it, is, well, fundamentally it's a progressive and profoundly destructive joint disorder.
Progressive and destructive. Okay.
Its initiation is tied to some form of trauma. Now, that could be a significant macro trauma, a fall perhaps, or more commonly, repetitive microtrauma.
Just day-to-day stress.
Exactly. To an extremity that already has pre-existing neuropathy. That's the key prerequisite.
The neuropathy has to be there first.
Precisely. And this seemingly innocuous trauma then triggers a cascade of events, leading to severe dislocations, fractures, and ultimately a complete collapse of the joint architecture.
Collapse, that sounds dramatic.
It is. And it's most frequently and notoriously observed in the foot.
Okay. And why is it such a challenge then? Why the urgency?
Well, the reason CNO presents such a profound challenge lies precisely in its, well, often insidious onset, its rapid progression once it starts, and the truly devastating consequences of delayed or incorrect diagnosis.
So time is absolutely critical.
Absolutely. A proper and critically prompt diagnosis, followed by immediate and frankly aggressive treatment of acute Charcot, is imperative.
And the goal?
Our overriding clinical goal here is always to decrease permanent foot deformity and, in an ideal scenario, achieve a stable, plantigrade foot.
Meaning a foot that can bear weight flat and naturally.
Exactly that. Suitable for ambulation. The consequences of a missed or delayed diagnosis can be truly life-altering for the patient. We're talking severe disability, chronic ulceration, infection, a drastically reduced quality of life. And it even extends to the risk of amputation.
Right, and you mentioned neuropathy. Is it always diabetes?
That's a common misconception. While diabetic neuropathy has, without a doubt, become the most common underlying cause for CNO, affecting between, say, 0.1% to 0.9% of people with diabetes.
Which is still a significant number.
It is, and there's a significant association with elevated body mass index, too. But it's vital that we broaden our perspective.
Okay.
Charcot can arise from a surprisingly wide range of peripheral neuropathies.
Such as?
For instance, we see CNO in patients with spinal cord injury, poliomyelitis, leprosy, syphilis, even syringomyelia. Chronic alcoholism is also a recognized cause.
That's quite a diverse list.
It is. And the sheer diversity of these underlying neuropathies underscores the necessity for a meticulous patient history and an unwavering high index of clinical suspicion, regardless of the patient's primary diagnosis.
So always keep Charcot in mind with a red-hot swollen limb in any neuropathic patient.
Precisely. You must consider it.
And regardless of the cause, what's the core issue?
Regardless of the specific underlying neuropathy, the core issue at play is an acute localized inflammatory condition.
Inflammation again.
Yes. This inflammatory response initiates a devastating cycle. It permanently disrupts the bony architecture of the affected limb, leading to structural instability and the development of abnormal plantar pressures.
Which then causes skin problems.
Exactly. These abnormal pressures create new areas of high stress on the skin, significantly increasing the risk for ulceration. And that ulceration then becomes a gateway for osteomyelitis, a severe bone infection.
And from there, amputation risk rises.
Tragically, yes. To put this into context, an estimated 63% of patients with CNO will develop a foot ulceration. That underscores the profound and ever-present risk.
63%, that's startlingly high.
It is. So while the reported incidence of Charcot might seem relatively low, its impact on the individual patient and indeed healthcare resources is incredibly high. It necessitates that unwavering clinical suspicion among orthopedic professionals and anyone managing patients with neuropathy.
That explanation truly underscores the sheer destructive power of this condition. It's clear neuropathy is the starting point, the vulnerability. But once that exists, what's actually happening at a physiological level? What are the theories? And how has our understanding, particularly about this inflammatory cascade, evolved?
That's an excellent follow-up. Understanding the why at a deeper level is crucial for effective management. The pathophysiology of Charcot is, well, it's complex, and whilst we've made significant strides, it's still an area of dynamic research.
Right.
Historically, two main theories have been put forward, and it's generally accepted now that both likely contribute to the catastrophic destruction we observe.
Okay, what are they?
The first is the neurotraumatic theory. This proposes that the underlying neuropathy diminishes protective sensation, the ability to feel pain, pressure, temperature, and also proprioception.
The body's sense of position.
Exactly. And this lack of sensation renders the affected limb acutely vulnerable. Patients simply don't perceive pain or abnormal joint loading.
So they keep stressing it without realizing.
Precisely. They continue to stress joints through routine activities without sensing the pain that would normally act as a vital warning signal. This leads to repeated microtrauma, a cumulative series of small injuries building up over time, ultimately resulting in severe joint destruction.
Like an uncontrolled demolition, as you said earlier.
That's a good analogy.
Mm-hmm.
The natural warning signals that would halt damaging activity are absent, allowing ongoing mechanical stress to just tear the joint apart.
And the second theory?
The second is the neurovascular theory. This posits that increased peripheral blood flow in a neuropathic limb contributes significantly to osteolysis, the pathological breakdown of bone tissue and widespread demineralization.
So too much blood flow is actually bad here.
In this context, yes. The dysregulated autonomic reflexes, common in neuropathy, lead to a hyperemic state, abnormally increased blood flow. This hyperemic state, rather than being beneficial, is actually thought to promote excessive bone resorption by activating osteoclasts.
The cells that break down bone.
Exactly, thereby weakening the bone structure considerably.
Okay, so trauma and vascular changes. But you mentioned inflammation.
Yes. While both these theories offer valuable insights, our modern understanding emphasizes that they are both profoundly underpinned by a specific and aggressive inflammatory response. This brings us to the crucial inflammatory cascade.
So it's more than just general inflammation.
Much more. Specific molecular players drive this destructive process. This is where things like RANKL come in.
Rank-ligand,
Yeah.
involved in bone metabolism.
Precisely. And another key player that's gained attention is calcitonin gene-related peptide, or CGRP. Normally, CGRP acts at the nerve terminal to antagonize the synthesis of RANKL.
It keeps rank-LM in check, normally.
Yes, but in the neuropathic foot, CGRP is either deficient or not functioning correctly. This leads to an uninhibited, rampant synthesis of RANKL.
And why is that so bad?
Because NR-RANKL is directly responsible for the proliferation of osteoclastogenesis, the process where osteoclasts, the bone-resorbing cells, are formed and activated. This uncontrolled osteoclast activity drives the excessive bony turnover and accumulation of bone fragments so characteristic of the Charcot limb. It effectively dissolves the bone from within.
A real molecular imbalance, then?
Absolutely. Furthermore, there's a delicate relationship between RANKL and another molecule called osteoprotoxarin, or OPG. OPG normally acts as a decoy receptor, blocking RANKL's destructive actions.
Like a safety catch.
Good way to think of it. In the Charcot foot, this finely tuned relationship is significantly disrupted, further skewing the balance dramatically towards unchecked bone destruction.
And CGRP has other roles, too.
Yes, there's more. CGRP is also involved in upholding the structural integrity of the joint capsule itself. Its absence or dysfunction is therefore presumed to contribute directly to the characteristic joint destruction and the rapid, often dramatic dislocation seen in Charcot.
So it's a combination of mechanical vulnerability, vascular changes, and this runaway inflammatory molecular cascade.
That's the current understanding. This complex molecular interplay helps explain the rapid, profound architectural changes. It truly is, as you put it earlier, a biological firestorm within the joint. Understanding these molecular drivers gives us new avenues to consider beyond purely mechanical approaches.
That's a true molecular firestorm. The key insight here, then, is that Charcot isn't just about lost sensation and mechanical stress. It's a specific, aggressive, inflammatory attack. So understanding this molecular imbalance, does this open new doors for targeted interventions beyond just traditional offloading?
Well, potentially, yes. That's the hope.
And given how insidious this process can be, what are those hallmark clinical signs we absolutely cannot miss? And perhaps even more critically, what are the common pitfalls and lookalikes that Charcot is often mistaken for, leading to those devastating delays you mentioned?
You've perfectly captured the evolving understanding. It's not simply mechanical, there's a profound inflammatory component. And yes, understanding this molecular drive does indeed open doors. While offloading remains the absolute cornerstone, ongoing research into anti-resorptive agents and AR-NKL inhibitors aims to specifically target this molecular imbalance.
Trying to dampen the firestorm at a cellular level?
Precisely. But for now, in day-to-day practice, our primary battleground is early recognition.
Which sounds crucial but difficult.
It is. Early recognition is absolutely paramount because of the unique way Charcot presents. A very high index of suspicion is necessary, especially because it often presents unilaterally, just affecting one limb with a surprisingly sudden onset of symptoms.
So what's the classic picture?
The classic presentation we look for is an erythematous foot, red and flushed with significant edema, swelling, and calor, meaning increased warmth to the touch.
Red, hot, swollen.
Yes. And this might be precipitated by either a clear macrotrauma, like an ankle sprain or a fall, or, more insidiously, just repetitive microtrauma from routine activities like walking or even ill-fitting shoes.
Okay. But you mentioned a challenge. The pain.
Exactly. One of the most challenging aspects and a significant diagnostic pitfall is what we call the pain paradox. Due to the underlying neuropathy, the affected joint can often be surprisingly painless.
No pain despite major destruction.
Or the pain might be remarkably disproportionate, far less than you'd expect given the severe destruction occurring. This lack of a clear pain signal is precisely what leads to significant diagnostic delays.
Because the patient doesn't feel the urgency.
Correct. It's truly unsettling. A condition actively demolishing a joint can occur without the usual alarm bells. This paradox contributes significantly to Charcot being misdiagnosed in up to 25% of cases.
A quarter of cases missed initially.
And leading to an average delay of 7 months in reaching the correct diagnosis. For a condition that can progress so rapidly, 7 months is an eternity.
Leading to worse deformities and outcomes.
Absolutely. As clinicians, we must actively navigate that inherent diagnostic blind spot, especially when a patient presents with warmth and swelling, but almost dismisses significant pain.
So vigilance is key. What are the common things it gets mistaken for?
Charcot is notoriously difficult to differentiate. Deep venous thrombosis, DVT, and cellulitis are very common initial misdiagnoses because the symptoms overlap: redness, swelling, warmth.
How can we try to tell them apart clinically?
One subtle clue: elevating the affected extremity for several minutes. Erythema typically decreases in active Charcot as the blood drains away temporarily, but it often doesn't change much in infection or DVT. It's not foolproof, but it can help.
Okay. What else?
Perhaps the most important and challenging differential diagnosis is osteomyelitis, bone infection.
Because they look so similar.
Clinically and radiographically, they can be strikingly similar. A red, hot, swollen foot with skeletalized bone destruction on radiographs. It's crucial to remember that while they are distinct entities, they can and often do occur simultaneously.
Making it even harder.
It does. And furthermore, there's growing evidence that osteomyelitis itself can actually cause Charcot, especially if surgery was performed to remove infected bone. Both osteomyelitis and surgical procedures are forms of trauma that trigger a profound inflammatory response.
Creating that fertile ground you mentioned?
Exactly. Leveraging that existing inflammatory cascade. Plus, biomechanical and gait alterations after surgery can create new pressure points, leading to further microtrauma and inflammatory events that perpetuate the cycle or even initiate Charcot.
A vicious cycle.
It can be a diagnostic nightmare, often needing advanced imaging or even biopsy to untangle.
Any other differentials to keep in mind?
Yes, we also need to rule out septic arthritis, gout, pseudogout, a simple foot or ankle sprain or fracture, and even complex regional pain syndrome, CRPS. A careful workup is needed.
And you stress the prerequisite of neuropathy.
Absolutely. The presence of neuropathy is an indispensable condition for diagnosing Charcot. Without it, the diagnosis simply cannot be made.
How do we check that reliably?
The 10-gram Semmes-Weinstein monofilament test is usually sufficient as a bedside screen to confirm loss of protective sensation.
And if there's doubt?
If doubt remains, more advanced investigations like nerve conduction studies or even assessment for small fiber neuropathy, using methods like quantitative pseudomotor axon reflex testing, QSART, or contact heat-evoked potentials can be invaluable.
Why small fiber neuropathy specifically?
Because small fiber damage can occur early in neuropathy and is strongly associated with Charcot. So a thorough neurological examination is as critical as assessing the orthopedic presentation itself. It's the foundational diagnostic pillar.
That truly highlights the critical need for a comprehensive assessment, and the neurological exam sounds absolutely non-negotiable. So given the potential for rapid progression to effectively manage Charcot, we clearly need a common language to describe its stages and anatomical locations. Could you walk us through the key staging and classification systems?
Absolutely. Having a standardized classification system is vital. It allows us to communicate effectively about the patient's condition, guide treatment, predict prognosis. It gets everyone on the same page.
Makes sense. Which ones are most commonly used?
The first, and perhaps most widely used, is the Eichenholz classification. This describes three main stages of disease progression based on clinical and radiographic findings, though it's often modified to include a crucial prodromal stage.
Stage 0.
Exactly. Stage 0, or the pre-Charcot prodromal stage. Clinically, you'll see that red-hot, swollen foot, but crucially, no visible deformity yet and often little pain.
And x-rays are normal?
Typically normal at this point, making it incredibly challenging. This is where advanced imaging, specifically MRI, becomes invaluable.
What does MRI show?
It reveals early signs like bone edema, indicating stress, or microfractures, soft tissue edema, and joint effusion, all signaling early disease activity. This is the critical window for intervention.
Because early offloading can prevent deformity.
Potentially, yes. Prevent full-blown Charcot deformity. Then comes stage I, the development or destruction phase.
What does that look like?
Clinically, marked erythema, significant foot edema, elevated temperature, often with that surprisingly little pain. Radiographically, this stage shows clear, often dramatic signs. Bony debris at joints, fragmentation of subchondral bone, joint subluxation, fracture dislocation, osteopenia.
The acute destructive phase. The joint literally crumbles.
That's right. Then we move to stage 2, or coalescence.
Things start to settle down a bit.
Clinically, yes. Signs of inflammation begin to decrease. The foot feels cooler, swelling may lessen. Radiographically, you initially see worsening of stage I features, but then, encouragingly, absorption of smaller bony debris starts, with new bone formation.
The body trying to repair itself.
Yes. You see coalescence of larger bone fragments and sclerosis of bone ends, indicating some increased stability, albeit with altered architecture. Stage 3, the consolidation stage. Clinically, inflammation has largely resolved. Foot feels cooler. Edema is significantly reduced. The foot architecture, however, is often permanently changed due to the final bony remodeling.
Leading to new problems.
Unfortunately, yes. These remodeled structures often create new pressure points and deformities, like a rocker bottom foot, placing the patient at high risk of ulceration even once the acute phase is over. Radiographically, consolidation is evident in a relatively stable, though often severely deformed, structure.
How long does this whole process take?
The resolution time through all stages is typically around 8 months, though it can rarely extend up to 2 years.
Yeah.
It highlights the chronicity.
Okay, that's the progression. What about location?
For that, we use the Sanders and Freiberg classification. This system is crucial for typing the 5 common anatomical locations within the foot. It helps standardize where the disease manifests, directly impacting treatment.
What are the types?
Type 1 involves the metatarsophalangeal to interphalangeal joints, about 15% of cases, often less severe but can cause hammer toes. Type 2 affects the tarsometatarsal joints. This is the most common, around 40%. It's the classic midfoot collapse, often leading to that dreaded rocker bottom deformity.
The Lisfrank's joint area.
Precisely. Type 3 involves the navicular-cuneiform, talonavicular, and calcanea cuboid joints, about 30%, so the central part of the hindfoot.
Right.
Type 4 affects the ankle and subtalar joints, seen at about 10%, often the most disabling, leading to significant instability.
And type 5?
Type 5, localized to the calcaneus, the heel bone, the least common, maybe 5%.
Is there any other classification worth knowing?
Well, the Rogers and Bevel-Ockwell classification is less used daily for staging, but it's worth noting. It's a 2-axis system combining anatomical location with severity, like Charcot with deformity, or with ulceration, or with osteomyelitis.
Oh, for prognosis.
Exactly. It helps assess the overall risk of limb amputation based on both the area affected and the presence of complications.
So, Professor, beyond just standardizing language, what's the single most critical reason a clinician must master these classifications? Is it prognosis, treatment guidance, or something else?
The single most critical reason, without a shadow of a doubt, is treatment guidance and prognosis. These aren't just academic exercises, they are fundamental to forming a treatment plan and communicating effectively across the whole team.
How so?
Knowing the Eichenholz stage dictates the urgency and type of offloading. Stage 0 demands immediate aggressive immobilization to prevent progression. Stage 3 shifts focus to protective footwear.
And the anatomical type.
That informs surgical planning. A type 2 midfoot collapse needs a different reconstruction than a type 4 ankle Charcot. It influences the orthosis, the hardware, even the rehab strategy. And Rogers and Bevilacqua underscores the amputation risk.
So there are blueprint for intervention and our crystal ball for prognosis.
In essence, yes. That's a good way to put it. They guide our actions and help us anticipate the future for the patient.
That's a powerful point, a blueprint for intervention. And speaking of blueprints, given the challenges of clinical diagnosis and the rapid progression, how do we confirm Charcot and perhaps even more importantly, track its progression? What imaging tools are essential and what are we specifically looking for?
Imaging is absolutely indispensable. It allows us to see the unseen destruction. We typically start with the most accessible tool.
X-rays.
Conventional radiographs, yes. They're the initial cornerstone. Purpose is to make and confirm a clinically suspected Charcot foot. You need at least weight-bearing DP, lateral foot, and AP ankle views. Mandatory.
What do we see?
In the very early prodromal stage, stage 0, they're often frustratingly normal. But stage I, you'll start seeing the characteristic bony fragmentation, subchondral sclerosis, joint subluxation or dislocation, osteopenia.
And serial X-rays are important.
Essential for monitoring progression through the Eichenholz stages and assessing angular measurements. For example, a lateral talar first metatarsal angle dropping below -27 degrees is strongly linked to developing plantar ulcers. It's an early warning sign.
Okay. What about MRI?
Magnetic resonance imaging. MRI has multiple critical roles. Firstly, early diagnosis. It can spot Charcot in stage 0 when X-rays are normal by identifying bone edema, stress fractures, effusions, vital for prompt offloading.
And for monitoring?
Yes. Secondly, invaluable for monitoring healing and the success of offloading. But importantly, MRI changes tend to persist longer than clinical signs.
How much longer?
Studies show mean clinical healing around 6.8 months versus 8.3 months for MRI resolution of edema. So relying only on clinical signs to stop offloading might increase reactivation risk. MRI helps guide duration.
That's a crucial point. And its third role?
Evaluating complications like osteomyelitis and deep soft tissue infections. It has superior soft tissue contrast.
What about CT scans?
Computed tomography CT is primarily for preoperative planning. It gives superb visualization of the extent and complexity of bone destruction, especially for reconstruction or removing bony lumps, exostosis.
Any other specific uses for CT?
It can be helpful for spotting intraosseous gas, cortical destruction, and sequestered dead bone fragments in suspected osteomyelitis. It gives a clear 3D map of the damage.
And nuclear medicine, bone scans.
Nuclear medicine imaging offers crucial differentiation, especially regarding infection. A technetium bone scan will be positive or hot for both neuropathic joints and osteomyelitis. Increased bone turnover in both, so less specific on its own.
Right. But there's another scan.
Yes, the indium white blood cell, WBC scan. This is highly useful for differentiating Charcot from osteomyelitis. It tracks white blood cells which flock to infection sites.
How does it differentiate?
It will typically be cold or negative for neuropathic joints because acute Charcot isn't primarily infective, but it will be hot, positive for osteomyelitis, offers high sensitivity and specificity in this critical differential, often decisive when osteo is strongly suspected.
What about ultrasound? Does that have a role?
Ultrasonography can detect soft tissue inflammation and even early bone changes like cortical irregularities before X-rays show them. Some supplementary value in the prodromal stage, especially for effusions.
And lab tests. Inflammatory markers.
Laboratory investigations play a supporting role. Systemic markers like ESR, white blood cell count, CRP, can all be elevated in active Charcot, especially early on.
Making it hard to distinguish from infection based on labs alone.
Exactly. They rise in both inflammation and infection, but they provide a baseline for monitoring activity. Ultimately, though, for definitive differentiation.
Biopsy.
Histology and biopsy are often essential, especially in ambiguous cases. Bone or synovial biopsies. Histologically, Charcot looks like severe degenerative joint disease. Ghost chondrocytes, subchondral cysts, sclerotic bone, fragmented cartilage.
And osteomyelitis looks different.
Distinctly. Shows plasma cells, lymphocytes, neutrophils indicating infection, plus reactive new bone and necrotic bone. So a multimodality approach leveraging each imaging type, labs, and biopsy if needed is the gold standard.
That multimodality approach certainly underscores the complexity. It sounds like early, decisive management is absolutely paramount, especially given the rapid progression and subtle signs. Could you explain the gold standard for treating active Charcot and delve into the nuances of non-operative strategies? What are the practical challenges in daily practice, and how do we overcome them?
Indeed, early and decisive action is the patient's best hope. The moment active Charcot is suspected or diagnosed, immediate offloading and a significant reduction of physical activity are crucial. That is the cornerstone.
Non-operative management first.
Absolutely. To prevent the development or worsening of deformity. We have strong evidence that early offloading in the prodromal stage can even prevent secondary Charcot deformity entirely.
And delays are bad.
Very bad. Treatment delays, even by WINTs, directly lead to more progressive deformities and more severe, often irreversible complications. The clinical stakes are incredibly high.
And the reason for offloading isn't just mechanical protection?
Intriguingly, no. It also seems to activate an inflammatory stage that actually contributes positively to bone remodeling and accelerated bone healing. It's guiding the biology, not just protecting the structure.
Fascinating. But you mentioned challenges, adherence.
Yes, a significant and persistent challenge is patient adherence. Failing to stick to the offloading regime is a massive risk factor for Charcot recurrence. The odds ratio is alarming, 19.7.
Almost 20 times more likely to recur if they don't adhere. Why is adherence so hard?
We're asking patients, who often feel little or no pain, to completely change their mobility and daily habits for months. It requires immense patient education, support, and buy-in.
How can we improve adherence?
If adherence is a concern, maybe consider short hospitalization with intensive physio instruction to ensure they understand and commit, or involve dedicated Charcot nurse educators, family members.
Okay. What about the devices themselves? What are the options?
Several options, each with pros and cons. The Total Contact Cast, TCC, is considered the gold standard. It's custom molded, maintains continuous contact with the entire plantar surface and lower limb, effectively redistributing and dramatically reducing pressures while still allowing protected walking. It also rapidly reduces swelling due to compression.
What are the downsides in practice?
It's labor-intensive, needs an experienced technician for meticulous fabrication, and needs frequent changes, often weekly initially, as swelling rapidly reduces. There's a reported complication rate around 5.5%, mainly pressure ulcers from improper fit or monitoring.
Can they be removable?
They can be made removable, but irremovable devices generally calm Charcot activity quicker because they enforce adherence. Takes away the temptation.
What about other options, like boots?
There's the Instant Total Contact Cast, ITCC, basically a removable walker secured with tape or fiberglass to make it non-removable by the patient. Lower cost, easier application than a traditional TCC, but perhaps not quite the same pressure redistribution.
And standard removable walkers, like a CROW.
Removable walkers, like the Charcot Restraint Orthotic Walker, CROW, or standard walking boots, can work if used correctly, but they suffer from significantly lower patient adherence compared to irremovable devices. Patients can just take them off.
Contraindications.
Contraindicated if there's significant volume fluctuation. And they have been linked to pressure pain, ulcers, muscular atrophy if used without strict adherence.
Any other devices?
Ankle-foot orthosis, AFOs. Individually made from a cast, often using transparent PTG material initially to check for pressure points before reinforcing. Particularly useful in stage 2, when swelling is stable, often used with compression stockings.
What about weight bearing? Strict non-weight bearing?
Historically, yes, strict non-weight bearing was advocated, crutches, wheelchair, but it's often unnecessary, leads to deconditioning, and is extremely hard for patients to comply with for months, especially without pain.
So what's the current thinking?
Current evidence suggests protected weight bearing with an irremovable device is the safest, most practical approach. It lets the acute process resolve while maintaining a stable, plantar-grade foot, preserving some mobility.
But unsupervised weight bearing is disastrous.
Persistent weight bearing without proper offloading leads directly to poor outcomes and ultimately limb loss, no question.
How long does the offloading continue?
Typically until clinical signs swelling, redness have completely regressed, and the temperature difference between the affected and unaffected foot is consistently less than 2 degrees C. We check that with infrared thermometry.
And how long does that usually take?
Usually up to 6 months. Though in rare, severe cases, it can extend to 2 years. It can be a very long haul for some patients.
And you mentioned MRI resolution takes longer.
Yes, MRI bone edema persists longer than clinical signs, being 8.3 months versus 6.8 months clinically. So some specialists advocate using MRI resolution to guide stopping offloading to reduce reactivation risk, especially in high-risk patients.
Are there any drug treatments that help?
Pharmacological treatments are largely adjunctive, still under research, definitely not a substitute for offloading.
Like what?
Antiresorptive agents. Bisphosphonates like pamidronate or zoledronic acid inhibit osteoclasts, potentially helping in the acute phase by dampening bone turnover. Some studies show modest reductions in pain and temperature. Calcitonin is another.
What about targeting ARNK directly?
Uricase inhibitors like denosumab, combined with the TCC, have shown promise in some small studies, potentially decreasing total immobilization time by targeting that molecular cascade.
But the overall evidence isn't strong yet.
Correct. A 2021 systematic review concluded current evidence doesn't strongly support routine use of antiresorptives or anti-inflammatories like methylprednisolone in addition to offloading for earlier remission. They might have a niche role, but mechanical protection is king.
What about once the acute phase is over? Stage 3 to management.
Management of inactive Charcot, Eichenholz stage 3, shifts focus entirely. Once active Charcot has resolved, the goal is providing protective footwear to prevent ulcers and bone injury from pressure. Plantar pressure elevation is almost universal due to the altered foot shape.
So special shoes.
Yes, commercially available depth inlay shoes, off-the-shelf or custom-molded multi-durometer foot orthosis, shoes with stiff walking soles and rocker bottoms to redistribute pressure.
What about severe deformities?
Custom-made orthopedic shoes, often crafted by artisanal shoemakers, are reserved for those. They might include extended shanks for instability.
And fitting them is tricky.
Requires meticulous attention to volume stability, as residual edema can persist. The transfer from offloading device to definitive footwear needs to be seamless. Patients should keep their TCC or CROW initially in case pressure points develop. Gradual wearing-in periods and daily self-checks are critical.
But complications still happen.
Despite best efforts, yes. Ulcers occur in 37–72% of patients, even in stage 3. Ulcer recurrence in 40–49%. Reactivation of Charcot in 7–33%.
And surgery might still be needed.
A significant percentage, maybe 42–56%, may still eventually require surgery for chronic deformities. And limb loss still occurs in 1–15% of cases. It underscores the ongoing lifelong challenge.
That's a sobering outlook for inactive Charcot, despite our best conservative efforts. This leads us to the critical point where surgery becomes necessary sometimes for the Charcot joint itself, sometimes to address the underlying neurological cause. Could you delve into the surgical considerations? What makes these procedures so challenging, and what are we aiming for?
Indeed, whilst non-operative management is the gold standard for acute Charcot, surgery plays a critical, often limb-salvaging role when conservative measures fail or a chronic deformity becomes intractable.
But the timing is controversial. Acute versus chronic.
Yes, the decision to intervene surgically in acute versus chronic Charcot remains debated. The acute phase involves that firestorm of inflammatory modulators, TNF-alpha, IL-1, IL-6 promoting edema, bone resorption, fragmentation. Operating in that environment is challenging.
Why? What are the risks?
Poor wound healing, increased infection risk, high rates of hardware failure. Many surgeons prefer to wait for Eichenholz stage 2 or 3 coalescence or consolidation when the acute inflammation had subsided.
So, what's the main reason to operate on Charcot?
The main rationale for Charcot reconstruction, when indicated, is primarily surgical offloading. The aim is to create a stable, plantigrade foot to prevent ulceration, stop deformity progression, and restore a functional limb for walking.
How is that achieved? What techniques?
Various techniques. Deformity correction can involve exostectomy, removing sharp bony prominences, causing pressure ulcers. Also, tenotomy to release contracted tendons contributing to deformity.
What about fusing joints?
Yes, the most common and robust approach is various isolated or multiple arthrodesis joint fusions, often using external and/or internal fixation.
Is the bone quality an issue?
Yes. Due to the typically softer osteopenic bone in Charcot patients, surgeons often double up on hardware, using larger or more numerous screws, plates, intramedullary nails to create a robust superconstruct.
To prevent it breaking down.
Exactly. Designed to ensure enduring stability despite compromised bone and ongoing neuropathic stress. Minimally invasive intramedullary techniques are also increasingly used by experienced surgeons to reduce soft tissue disruption.
So fusion is common. What about joint replacement, arthroplasty?
Arthroplasty is more complex and often controversial for Charcot, particularly for joints like the shoulder and elbow.
Why the controversy?
Significant challenges: local bone and soft tissue loss, the crucial lack of protective sensation post-surgery, meaning the patient won't feel pain if the prosthesis loosens or becomes unstable, and often altered muscle control. All raise concerns about prosthetic loosening, instability, early failure.
So it's often contraindicated.
Frequently listed as a strict contraindication for many FDA-approved shoulder arthroplasties, highlighting the perceived risk.
But is that changing?
Emerging literature suggests arthroplasty can be a viable off-label option for select patients with Charcot shoulders or elbows. Typically those who failed conservative management and, crucially, whose underlying neurological condition has been treated or managed, stabilizing the process.
What are the outcomes like?
Studies show shoulder arthroplasty can provide substantial pain relief and improved motion, although gains might not be as dramatic as in other conditions. One series showed mean elevation improved to 105 degrees, external rotation from 20 to 43 degrees, meaningful functional gains.
What types of replacement?
Hemiarthroplasty, total shoulder, reverse shoulder have all been performed. Outcomes show improved function in about 70% at 5-year follow-up for the shoulder, especially with diligent physio. But complications like glenoid erosion in hemiarthroplasty or acromial stress fractures in reverse total shoulder are recognized risks. Must be discussed carefully.
You mentioned addressing the underlying neurological cause being paramount.
Absolutely. It often dictates the long-term orthopedic outcome. For conditions like syringomyelia, the most common cause of upper extremity Charcot, about 75% of shoulder cases, neurosurgical decompression of the syrinx is critical.
What does that involve?
Various procedures: posterior fossa decompression, craniotomy, syringoperitoneal shunting to drain fluid, laminectomy. Crucially, decompressing the syrinx has been shown not just to slow disease progression and maximize joint function, but also improve bone quality.
Improve bone quality, really?
Yes, there are documented reports of regrowth of the glenoid fossa in some shoulder cases, and even some elbow joint space restoration after syrinx decompression. It truly highlights the profound importance of addressing the root neurological pathology. It directly impacts the orthopedic outcome.
That's incredible. What about preparing the patient for surgery?
Medical optimization preoperatively is paramount. Strict smoking cessation. Excellent HbA1c control, ideally under 7–8% for diabetics. Recognizing and aggressively managing any micro or macrovascular disease.
Why is this so important?
Crucial to lessen potential post-op complications, particularly surgical site infections, which can be devastating in these vulnerable neuropathic patients and easily lead to limb loss. Holistic preparation is key.
That's fascinating, Professor, how addressing the underlying neurosurgical cause can actually promote bone regeneration. We often hear about Charcot affecting the foot, but as you've highlighted, it can manifest in various joints. What are the specific considerations when Charcot affects the upper extremities, shoulder, elbow, wrist? What should we look out for if it's not the foot?
You're right. The common perception is foot and ankle. And it's true, Charcot neuropathic osteoarthropathy is overwhelmingly seen there, with those Sanders and Friedberg patterns. Diabetes is the usual culprit for lower limb Charcot.
But upper limb is different.
Involvement of upper extremity joints is exceedingly rare. This rarity often leads to significant diagnostic delays because it's just not top of mind. Clinicians might attribute symptoms to more common orthopedic issues.
And the cause is usually different too.
Typically linked to different underlying neuropathies than in the foot, making the differential even more challenging.
Let's start with the shoulder then.
Okay, shoulder involvement. Prevalence is uncommon. Only 5–6% of all neuropathic arthropathies, fewer than 70 cases historically reported. The cause: overwhelmingly syringomyelia, responsible for about 75% of Charcot shoulder cases, often a syrinx, a fluid-filled cyst in the cervical spinal cord.
How do these patients present?
Often with diffuse, often painless, swelling of the shoulder, limited active range of motion, but you might see surprisingly exaggerated passive movements due to joint laxity and destruction.
Other signs:
muscle wasting around the shoulder girdle, reduced sensation and a classic cape-like distribution across shoulders and upper chest, a strong indicator of a cervical spine lesion, like a syrinx, and diminished or absent upper limb reflexes. The lack of pain is, again, the critical diagnostic pitfall.
What about imaging for the shoulder?
Radiographs can show characteristic changes: superomedial flattening of the humeral head, extensive periarticular soft tissue calcifications, glenoid sclerosis, widespread bone resorption, eventual subluxation or dislocation. Given the strong link, A dedicated cervical spine MRI to look for a syrinx is absolutely critical.
And management.
Non-operative first. Rest, immobilization in a sling, activity modification. Surgical options like arthrodesis for severe pain stability, or increasingly shoulder arthroplasty in selected stabilized cases, despite historical contraindications. And as we discussed, neurosurgical decompression of the syrinx is paramount, can even promote some bone regeneration.
Okay, what about the elbow? Even rarer.
Elbow involvement is even rarer. Approximately 40 reported cases. Again, syringomyelia is the most common cause. Ulnar neuropathy is also frequently associated, often due to compression at the elbow secondary to the syrinx.
Presentation similar to the shoulder.
Similar in some ways. Swollen elbow can be painful or crucially painless. Loss of active motion is common. The joint might exhibit marked mechanical instability, feeling loose.
Any specific nerve signs?
Signs of ulnar nerve entrapment are frequently observed.
Okay.
Paresthesias in the little finger and ulnar ring finger. Interosseous muscle weakness, sometimes progressing to muscle atrophy or clawing of the hand.
Imaging for the elbow.
Radiographs show joint space obliteration, extensive fragmentation of articular surfaces, potential subluxation or dislocation. And again, cervical spine MRI is necessary to rule out a syrinx.
Management.
Non-operative first. Rest, NSAIDs if painful, functional bracing, activity restriction. Neurosurgical decompression of a syrinx is indicated. Peripheral nerve neurolysis for ulnar nerve palsy is considered, though recurrence can be high. Elbow arthrodesis is an option for pain instability, but total joint replacement is generally contraindicated due to poor bone stock and high complication risk.
And finally, the wrist. Extremely rare, you said.
Wrist involvement, yes, exceedingly rare, almost always a diagnosis of exclusion.
Cause. Still syringomyelia.
Primarily, yes. In the wrist, syringomyelia is more frequent than diabetes. Though diabetic neuropathy has been reported in isolated cases, other rare causes include tabes dorsalis, leprosy,
Clinical picture.
typically painless swelling and progressive deformity of the wrist. Despite advanced degenerative changes on imaging, the lack of pain leads to significant diagnostic delays, sometimes years. A thorough neurological exam, often revealing myelopathy or sensory deficits, is critical.
Can you give an example?
Yes, we encountered a 64-year-old male with progressive, painless right wrist swelling and deformity over 2 years. Neurological exam revealed widespread signs, diminished pain-time sensation in all limbs, reduced strength, hyperreflexia. Imaging confirmed severe cervical spine degeneration, and MRI showed a type 2 Chiari malformation with a large syrinx from C2 to D2.
And his wrist.
Wrist x-rays showed extensive sclerosis, carpal collapse, fragmentation, classic Charcot, a perfect example of upper extremity Charcot linked to a central lesion like syringomyelia. It's crucial to rule out common things like RA, TB via labs, histology. Misdiagnosis leads to wrong treatments. That patient initially got anti-TB meds after a biopsy, highlighting the challenge.
Management for the wrist.
Non-surgical preferred initially in stages 1 and 2, wrist splinting, functional therapy to offload and stabilize. Surgery like fusion is reserved for advanced stage 3 or significant instability pain. And again, managing the underlying neurological cause, like neurosurgical decompression for myopathy, is essential to potentially delay further joint destruction.
So the theme for upper limb Charcot is rarity, often painless, investigate central causes like syringomyelia.
Exactly. Rarity, painless presentation causing delay, and the critical need to look for central neurological causes, contrasting sharply with the common diabetic cause in the lower limb.
Professor, it's clear Charcot is a profoundly serious condition with that unique upper limb presentation. What does the long-term prognosis look like? What are the most feared complications? And perhaps, most importantly, how do we best educate and support our patients in preventing these devastating outcomes?
This is a vital question. The long-term implications are profound. While the acute inflammatory phase typically resolves over about 8 months, the disease carries a significant, persistent risk of severe complications throughout life.
Like the ulcerations you mentioned.
Yes, studies show a striking 67% of Charcot patients develop complications like ulcerations. It underscores the relentless nature. And non-adherence to the treatment plan significantly worsens prognosis, highlighting the central role of patient education and compliance.
What are the major complications we're trying to prevent?
Firstly, foot deformities, the hallmark of untreated or poorly managed Charcot. Progressive destruction leads to severe architectural changes. Flat foot, the notorious rocker bottom foot, where the midfoot collapses, making the sole convex, hammer toes, ankle equinus contracture. These fundamentally alter foot biomechanics,
Leading to?
ulceration and infection. These deformities, especially sharp bony prominences, create abnormal pressure points, highly prone to neuropathic ulcers. These aren't just skin deep, they're gateways for bacteria, leading to soft tissue infections, cellulitis, and critically, osteomyelitis.
Which increases amputation risk.
Significantly, the progression from ulcer to underlying bone infection dramatically increases the risk of major lower extremity amputation. A rocker bottom foot increases this risk by a staggering 15 to 40-fold.
15 to 40 times, that's huge.
It is, and it's a sobering fact. Major amputation in a diabetic patient carries a 5-year mortality rate of 30% to 80%. That surpasses mortality rates for breast and colon cancer.
That puts it into perspective.
While the 5-year mortality from the first diagnosis of acute Charcot itself is around 13% similar to diabetics without Charcot, the mortality after major amputation is a stark reminder of the disease's severity and its systemic impact.
Any other major complication?
Recurrence. Charcot joint recurrence is a recognized complication. It needs lifelong vigilance. It's not a condition that just resolves. It requires continuous monitoring and adaptation.
Given these severe outcomes, deterrence and patient education are paramount.
Absolutely critical. This is where we empower patients to be active participants.
How do we approach that education?
Firstly, explaining the magnitude of the condition. Patients must fully comprehend the gravity and the potential life-altering complications if strict adherence isn't followed. No sugarcoating, but communicate with empathy and clarity.
Explaining the stark choices.
Yes, the risk of multiple stage reconstructions versus progression to a rocker bottom deformity, ulceration, infection, potential amputation. Use visual aids, analogies, repeat discussions.
What about day-to-day prevention?
Basic prevention guidelines are paramount. Rigorous daily self-foot checks involving relatives if needed, looking for redness, swelling, warmth, blisters, skin breaks. Meticulous glucose control, HbA1c under 70%, is fundamental. Consistently wearing proper footwear, accommodative, well-fitting, protective soles, both inside and outside. And diligently avoiding injury, however trivial.
Lifestyle factors. Weight. Gait.
Weight reduction can significantly help reduce plantar pressures. Adapting gait, reducing stride length, using a step to gait can also reduce peak pressures.
And protecting the other foot.
Crucial. The unaffected contralateral foot is also at high risk, often within 5 years. So immediate protection with accommodative footwear for both feet is often recommended.
Anything else to check?
Always thoroughly evaluate for peripheral arterial disease, TAD. Its presence correlates with worse treatment outcomes and impaired healing. Optimizing vascular status is vital. Long-term management is truly a marathon, demanding continuous vigilance and a strong patient-team partnership.
That long-term perspective and emphasis on patient education are so critical. It leads me to my final question. Charcot is a condition that truly demands a holistic approach. Could you elaborate on the vital role of the interprofessional team in managing these complex patients? Because no one clinician can do this alone, can they?
You've perfectly captured it. Charcot is the quintessential condition demanding a truly holistic, interprofessional approach. The complexity, the multifaceted causes, the devastating potential mean no single specialty can manage these patients alone.
And mistakes are costly.
Any error in diagnosis or failure to treat promptly can rapidly lead to progressive damage and amputation. The overarching aim of the entire team must be to prevent progression and avoid limb loss. It's a race against time, and we all have to run together.
Who are the key players on this team?
Firstly, podiatry and/or foot and ankle surgery. Often at the forefront, making the initial diagnosis, implementing offloading, managing deformities, performing debridements, surgical interventions, their expertise is fundamental.
Then the medical side.
Endocrinology and order internal medicine, essential for optimizing underlying conditions, especially diabetes, HbA1c control, addressing metabolic issues impacting bone health and healing.
Wound care is crucial too.
Yes, a certified wound physician. Critical for managing ulcerations, preventing infection, guiding advanced healing strategies, selecting dressings, knowing when debridement is needed.
And if infection does set in?
Infectious disease specialists, indispensable for suspected or confirmed osteomyelitis. They guide antibiotic therapy, often prolonged and complex, and collaborate with surgeons on debridement.
What about rehabilitation?
Physical and occupational therapy, crucial for maintaining range of motion, strength, gait training to minimize pressures, helping patients adapt to offloading devices and footwear, restoring functional ambulation safely.
Debard at home?
Home health services provide vital support for education, daily foot checks, wound care, adherence, especially for those with mobility or visual issues. Bridges the gap between clinic visits.
And the device specialists.
Orthotists and/or podorthists Absolutely essential for fabricating and fitting custom offloading devices, TCCs, AFOs, and therapeutic footwear, ensuring proper pressure redistribution and protection for both feet. Integral to long-term management in inactive Charcot.
So communication is key.
The cornerstone of success is coordinated care. Effective communication and seamless coordination among all team members are paramount. Regular multidisciplinary meetings, dedicated Charcot clinics, clear communication channels ensure comprehensive care.
A true team effort.
From acute management to long-term prevention and patient education, this integrated, coordinated effort significantly improves outcomes, reduces complications, and preserves limb function. It's truly a team sport, and every player is indispensable.
What a truly comprehensive deep dive into Charcot neuropathic osteoarthropathy. Your insights have profoundly illuminated this challenging condition for our orthopedic professionals. We've journeyed from its subtle onset and complex pathophysiology right through to the critical importance of that interprofessional management.
It's a complex area, definitely worth a deep dive.
The key takeaway, I think, if you take one thing away from our conversation today, is that a high index of suspicion, timely diagnosis, and a relentless, unwavering commitment to offloading and multidisciplinary care are your most powerful tools in preventing the devastating complications of Charcot.
Couldn't agree more. Vigilance and teamwork.
This deep dive has hopefully provided you with the nuanced understanding needed to make a real difference for your patients. If you found this discussion valuable, please do consider leaving us a rating and sharing this deep dive within your professional network.
It helps get the word out on important topics like this.
It certainly does. Thank you for joining us on Deep Dive Ortho. Until next time, keep exploring, keep learning, and keep making a difference in orthopedic care.
Thank you.